Okay, Dr. Merjanian is back for a contraceptive update. She'll go into some more details of some of the things that she touched on briefly yesterday and let us know if there's anything new out there in the world of contraception. I also just want to mention tomorrow morning, if you look at the syllabus for tomorrow morning, the first thing on the syllabus is a panel discussion about menopause, and that is at 7 o'clock. And then if you look down further, at 10:15, I was going to do a talk on menopausal hormone therapy. So what we're going to do is flip-flop those two lectures. So I'll do the menopause hormone therapy talk first, and then we'll do the panel later in the morning. I think that way we will have covered a lot of information, and then we can cover a lot of other things when we actually do the panel. Okay, so just to let you know.
Thank you. So good morning again. So now that we've gotten our patients pregnant, we've helped them deal with their depression and anxiety, allowed them to exercise in pregnancy. Now we're going to talk a little bit about some of the pregnancy prevention updates that we have. So we're going to review the U.S. medical eligibility criteria for contraceptive use. I'm sure many of you are already familiar with it, but we're going to review the basic format of that and how it helps us in our decisions with contraceptives. We're going to review some of the permanent contraceptive updates. There are primarily two of them to go over. We'll review the hormonal contraception and the risk of breast cancer, because that's something that patients often talk to us about. And then we're going to review some of the emergency contraceptive updates as well. So family planning, the umbrella term for the person's plan regarding whether and when to have children. Family planning includes strategies to both prevent pregnancy when it's unwanted and also help women get pregnant when it's actually desired. So unintended pregnancies are those that were not desired, can be mistimed pregnancies, or they could be unwanted pregnancies. As per ACOG, pregnancy is defined as the period from implantation to termination or extraction of the fetus. Therefore, contraception is any means of pregnancy prevention, including emergency contraception. So about half of the pregnancies in this country are unintended. We actually have much higher rates than other developed countries. 40% of the unintended pregnancies result in elective termination, and about 27% result in birth. Some populations are more affected. Women of color have more unintended pregnancies. As we talked about in adolescence, 6% of teenagers will become pregnant each year, and 75% of those are unintended. So this really is a really important topic to talk to our patients about in their reproductive years. Why is evidence-based guidance needed? So up until several years ago, so we know that half of our pregnancies are unintended, and nowadays we have so many new methods to offer patients, but we really need some guidance in helping us figure out, for patients with certain medical problems, which of the methods that we have available are actually safe to use. And years ago, we really didn't have the information or the data. Doctors would use their textbooks to figure out what they should be using, or they would just use their own personal experience, not necessarily use evidence-based guidance. And that's where the US MEC actually is really helpful for us. And it's organized in a very user-friendly way as well, and we'll review that in a little bit. We also want to address misconceptions. Some people just assume, oh, yeah, I don't know, I heard that you can't use that birth control method for that medical condition, but when you actually have guidance that helps you figure it out, you can, I think you can make a better informed counseling session with your patient. And we also want to, of course, improve the quality of the family planning options that we have for our patients. So basically, for years, the US providers have relied on World Health Organization eligibility criteria, which provided recommendations on the safe use of contraceptive methods for women with various medical conditions. And what the US medical eligibility criteria do, it's it's focused on our US population. So in addition to what WHO has recommended, the CDC guidance includes other conditions relevant to the US patient population, including things like patients with solid organ transplantation, bariatric surgery, peripartum cardiomyopathy, endometrial hyperplasia, and inflammatory bowel disease. It includes over 1,800 recommendations for over 120 medical conditions. And ongoing monitoring occurs so that when new studies come out, that their criteria is actually updated. So there's also the companion document to US MEC, and it's the US Selected Practice Recommendations for Contraceptive Use. And then this was first published by the CDC in 2013. It's also adapted on WHO standards. And how this document helps us, it helps provide evidence-based guidance on how to use contraceptive methods safely and effectively once they're deemed medically appropriate. So the US MEC helps you figure out which patient can get which method based on their medical eligibility for it, and then the US Selective Practice Recommendations can help guide you when you have some side effects of medications, and also how to safely continue medication use. And they also update their recommendations as well. It helps with the US SPR. It helps provide the guidance in trying to figure out when you're reasonably certain that a woman is not pregnant, which is what we talked about in the other lecture yesterday about the quick start method and the algorithm of how to figure out when women are reasonably not pregnant so that you can start them on birth control methods. It helps you figure out when to start a woman on birth control, what are some medically indicated exams and tests, and how you follow up and manage some problems that may occur because of methods that you're using. So let's go back to the US MEC. So in terms of classification, for each patient characteristic or medical condition, eligibility criteria for the particular method is listed in terms of 4 rankings. So when a method is ranked under the US MEC chart, when you look at it, when it's 1, that means there's no restriction for the use of that contraceptive method for that particular condition that you're looking up. When it is labeled as a level 4, then using that particular medication in that patient with that particular medical problem is an unacceptable health risk. And then you have 2, so the advantage of using the method generally outweighs the theoretical or proven risk. And then you have the 3, which is in between. The theoretical or proven risks of the method usually outweighs the advantages, but not usually recommended unless a more appropriate method is not available or it's acceptable. So 1, 2, 3, 4. So 1 and 2, and it's also color coded. So when you actually look at the chart, when you go to CDC's website for the US MEC, you can quickly see if something's in the green, that means it's a go. If it's a red, it's an absolute contraindication. And if it's in that pinkish shade, you have to be careful about the medication and you would use it only if you can't find a better method. So the contraceptive methods that are included in the US MEC are all the methods that are currently available. There is guidelines for the intrauterine devices, both the progestin-only ones and the copper IUD. There are recommendations for progesterone-only contraceptives, for the combined hormonal contraceptives that include the pills, the patches, the rings, emergency contraceptive pills, the barrier methods, fertility awareness methods, lactational amenorrhea, coitus interruptus, and female and male sterilization. They also have a chart of family planning effectiveness, which I think is also very useful. And this is really a nice chart for a patient to look at as well. You know, something that you might want to put in your office, just because it's very easy for the reader to understand. And so the way that they have the different methods on this chart is the most effective methods are up top on the chart, and you can see with the arrow, and then the least effective methods are down here. And then in terms of the first row of methods. These are the most effective and they're reversible here. So you can see that the implant and then the IUDs, so these are our LARCs. And then you have your permanent effective methods, right? So you have your female and male sterilization. And then in the second row, you have your reversible, not permanent methods. So you have your injectables, the oral contraceptive pills, the patches, the rings, and diaphragms. And then you have the lesser effective methods with male and female condoms, withdrawal method sponge, and it tells you the efficacy of each. And over here, it tells you, in a given year, what number of patients generally can expect to get pregnant using those different methods. And so again, very user-friendly way of looking at this, different methods that are out there. So if you look at, say, one of these methods, so let's look at smoking and contraceptive use. This actually isn't color-coded, but if you look in the, like I said, if you actually look in their chart, it's color-coded with the greens and the pinks and the reds. So if you look at, so you have up here, you have the different contraceptive methods written. So you have the copper IUD, you have the progestin IUD, you have the implant, you have the Depo-Provera, the progesterone-only pills, and the combined hormonal contraceptive methods. So that goes this way. And then you have your condition, and if the condition is broken up further, it will indicate it in the chart. So generally speaking, if you have a patient who's a smoker, who's under the age of 35, who has no other contraindications, right? Using all these methods are 1, 1, 1, 1, 1, and this is 2. And so this will all be in the green, right? So you can use combined hormonal contraceptives in a smoker under the age of 35 because it's a 2. You have to be careful now, right? When a woman has reached 35 and she smokes, notice how if she's a heavy smoker and they define heavy as greater than 15 cigarettes a day, using combined hormonal contraceptives is a 4, right? It's an absolute contraindication. And if she is over the age of 35 and she smokes less than 15 cigarettes a day, using combined oral contraceptive methods is a 3, right? So it's in that pink. Generally our rule of thumb with smokers who are over age of 35 is we really try to find methods that are not estrogen-based so that we decrease their risk of heart attacks, strokes, and blood clot formation. But then you can see for all the progesterone-only methods and the copper IUD, right, these are 1s. So you might want to really consider these methods in your smoker who's over age of 35. So this is sort of how you use the chart for each medical condition. And like I said, there's like a gazillion medical conditions that have this type of information available. And then so they also have a chart that says that are the conditions associated with increased risk of adverse health events as a result of unintended pregnancy. So patients with these medical problems, breast cancer, diabetes, endometrial ovarian cancer, epilepsy, hypertension, lupus, history of bariatric surgery, all these patients, right? Those patients who get pregnant are at much, much higher risk. So it's really important for patients with these medical problems that you help the patient pick the most effective method to prevent pregnancy. So in the 2016 updates in the US MEC, they updated it to include 4 new medical conditions, including cystic fibrosis, multiple sclerosis, women using SSRIs, women taking St. John's wort. They made an update about the use of ulipristal acetate, which is UPA, which we'll talk a little bit about it later on, which is it's probably the newest emergency contraceptive method that was FDA approved a couple years ago. They made some changes to existing recommendations about migraines, superficial venous disease, women using antiretrovirals, women with known dyslipidemia. And they also made some changes to the recommendations for intrauterine devices with women with gestational trophoblastic disease, postpartum and breastfeeding women, HIV, and factors related to sexually transmitted infections. At the end, we'll have a couple of cases just to go over, and we'll touch upon some of these recommendations. One thing to see for 2017, that was an update, was the use of hormonal contraception among women at high risk for HIV. So this is just something interesting. So in accordance with WHO, CDC updated the clarification for the use of Depo-Provera, so Depo-Provera is DMPA, which highlights that there continued to be evidence of a possible increased risk for HIV acquisition among women who use progestin-only injectable contraceptives. We don't know, it's not clear whether this is a real biologic effect or due to methodological issues with the studies. So we don't know why that is possibly an increased risk for the women who use progestin-only injectable methods. However, women should not be denied the use of Depo-Provera because of these concerns. They should be advised of the concerns, as well as we speak to all patients about HIV prevention measures, but a patient should not be denied Depo-Provera even if she's at high risk of HIV, even if she has behaviors that put her at higher risk of HIV. For implants, progesterone-only pills, and combined hormonal contraceptives, the US MEC recommendations remain the same. These methods can be used without restriction among women at high risk for HIV infection. I mean, unless they have other medical conditions that prevent them from using that method. So I just thought that was interesting for us to be aware of. So let's talk a little bit about permanent contraception. According to recent data, 62% of women of childbearing age between 15 to 44 use some method of contraception. Of those, about a quarter of them rely on permanent contraception, making it one of the most common methods used by women in this country. So women can have a permanent contraception procedure done immediately postpartum, where we do our postpartum tubal ligations, which occurs after about 9% of all hospital deliveries in this country. Or it could be done as an interval, which means that it's unrelated to her giving birth. And the methods that we use are usually either laparoscopic or hysteroscopic in terms of the sterilization method. So the one update that I wanted to just talk to everybody about was for the hysteroscopic occlusion. So hysteroscopic occlusion is one of the newest permanent sterilization methods. It was actually introduced in 2002, where we have the ability to insert these metal coils into the ostia of the tubes hysteroscopically, with the goal of, after about 3 months, that produces enough scar tissue to occlude the tubes. The FDA in 2016 added a black box warning for this procedure, and they added a patient decision checklist, because I think what had happened was patients were getting this procedure done, and it was being done very frequently because it potentially was done in the office. It did not include any incisions. It was all done hysteroscopic. People were getting them done, but there was complications from happening. Patients were having post-procedure pain. There were patients that had to be reoperated on. The little metal devices, we had to remove them. Sometimes we actually had to remove the tubes. And so what I think happened was they felt as if patients weren't being advised about it enough and were not advised about the complications enough. And so that's when the FDA put this black box warning on it, so that now there's a 4-page checklist to go through prior to a patient actually having the procedure done, which I think has also generally, I mean, I can speak for our practice, we're significantly doing less of these procedures nowadays as well, since this came into effect. But again, important to know. Let's talk a little bit about contraception and the risk of ovarian cancer. So ovarian cancer has the highest mortality rate out of all gynecologic cancers, and it's the 5th leading cause of cancer death in women. The overall survival rate for women with epithelial ovarian cancer has marginally improved over the last 50 years. The most aggressive epithelial ovarian carcinomas represent 75% of all cases of ovarian cancer and responsible for about 90% of deaths due to ovarian cancer. Current attempts at screening for ovarian cancer are unsuccessful. We really don't have a good method. We don't have a good blood test. We don't have any good imagings that we can order like we have cervical cancer screening. We just don't have good ovarian cancer screening right now. And so the update that I wanted to talk about with permanent contraception relates to to possibly offering patients salpingectomies at the time of tubal ligation. So the most compelling theory of epithelial ovarian carcinogenesis suggests that serous endometrioid and clear cell carcinomas are actually derived from the fallopian tube and the endometrium. They're actually not directly derived from the ovary. So this is in contrast to the traditional view of ovarian carcinogenesis, in which ovarian surface epithelium undergoes metaplastic changes that lead to ovarian cancer. So what the thought is now that if we offer a prophylactic salpingectomy at the time of a laparoscopic tubal ligation, it can offer us the potential to prevent ovarian cancer in women. And again, I know the OBGYNs here, we probably are familiar with this, right? But we often did a partial salpingectomy, or we just did an occlusion, or we just occluded and we cut the tube in the traditional tubal ligations that we did. But now what I was referring to is actually removing the entire tube for actually ovarian cancer prevention. So let's talk a little bit about hormonal contraception and the risk of breast cancer. In 2017, in December, the New England Journal of Medicine published a cohort study analyzing the risk of invasive breast cancer in women using hormonal contraception. The study was really designed to assess the influence of hormonal contraceptive use on the development of cardiovascular disease and cancer in Danish women. So the authors found some interesting things. So authors found, compared to women who never used hormonal contraception, the overall relative risk of invasive breast cancer among women who are current or recent users of hormonal contraception was 1.20. So it was statistically significant. The relative risk of breast cancer slightly increased with the longer the oral contraceptive method was used. But the results for progestin-only methods were inconsistent and not conclusive. They did not see a significant increased risk with Depo-Provera and the implants. However, when they looked at the progestin IUD, there was an increased relative risk of breast cancer, which were similar to the combined oral contraceptives, but remained unchanged with the duration of use. But you have to, again, put this information into the context, right? Overall, the breast cancer rate is low, and so if you have a slightly increased risk of breast cancer in the combined oral hormonal contraceptives or the IUD, you have to use it in context of you're not talking about large numbers to start with. But you also have to look at it in other ways as well. Because hormonal contraceptive methods, right, combined hormonal contraceptives also have other medical benefits. So they have significant health benefits, and we know that there is decreased risk of ovarian cancer, endometrial cancer, and colon cancer. So you may have a small increase of breast cancer, but you also have all these other health benefits, and so you have to use it in the overall context. And this is, a tough discussion to have with patients too, because everybody's worried about it. And so these are some of the things that you can talk to patients about. So because of the protection against other cancers, the overall cancer risk may be slightly lower in hormonal contraceptive users rather than the non-users. And then the other thing to remember is, it's important to prevent pregnancy in patients who shouldn't be getting pregnant, who don't want to get pregnant as well. And so you have to put that into the context of the whole discussion as well. And again, things may change, right? As more studies come out, it's always going back and forth about some of these topics that we're talking about. but this is what the most update is right now. So the other thing I wanted to talk about was the update about emergency contraception. So emergency contraception may be used to prevent pregnancy after unprotected sex, inadequately protected sex, or may result of rape, assault. It is effective. Emergency contraceptive, when used by the right patient with the right timing, is effective in preventing pregnancy within 120 hours after unprotected intercourse, but it's most effective the earlier it's used. So for our progesterone-only methods that we traditionally use, it's the most effective within the first 72 hours, most effective, even more effective if it's used within 24 hours. So the one that I'm going to talk a little bit more about, because I think it's the one that we're probably the least familiar about, because it's the newer one, is the ulipristal acetate, or UPA, which is a selective progesterone receptor modulator. Just some other facts to know about emergency contraception. The copper IUD is actually the most effective form of emergency contraception, and it offers the ability to have contraception for 10 years after placing it as well. And we can use the copper IUD as a emergency contraception for up to 5 days after unprotected intercourse. So let's talk a little bit about UPA, the selective progesterone receptor modulator. In the context of what we're using it now, it's mostly anti-progestin. It prevents ovulation, and it thins out the lining of the endometrium. It's actually, the studies are showing that it's more effective than progestin-only emergency contraceptive in preventing pregnancy for all time points within the first 120 hours, so within the first 5 days. It does require a prescription to use. Recent evidence indicates that the progestin IUD, the progestin-only contraceptive method, and the UPA may be less effective for women who are overweight or obese, although the progestin method may lose efficacy at a lower weight threshold than UPA. We don't use weight as telling patients that they should not take emergency contraception, just that there may be some less efficacy to it. And like I said before, regardless of a woman's body weight, the copper IUD is the most effective form of emergency contraception, then followed by UPA. Couple of other things just to know about UPA is that you should not use it in women who have liver disease. You should not use it in women who are currently breastfeeding, because if they are breastfeeding, they actually should pump and dump for at least 36 hours afterwards. The other thing that some studies are suggesting in animal models, that UPA is actually embryotoxic, which is why it's also important that the patient is not pregnant at the time that she starts UPA. With our other emergency contraceptive methods that we have, we don't have studies that say that they are embryotoxic. This particular one is. So we have to be careful about exactly who we use it on as well. So let's see, where was I? So the update in 2016 by the US SPR about UPA was about when to start regular contraception after using UPA. So you want to start or resume hormonal contraception no sooner than 5 days after the use of UPA. For all our other emergency contraceptives, you can start your regular contraception immediately with the method that they were using. But with UPA, no sooner than 5 days, because there is some suggestion that they interfere with each other, actually. What else? And then we always do tell our patients after taking an emergency contraception, and even if they resume a regular contraceptive method, that they should either abstain or use another method to protect against pregnancy for 7 days afterwards as well. And then hopefully await for their period to happen about 2 to 3 weeks after taking it. And if she doesn't have her regular scheduled period, then she should take a pregnancy test. So those are some of just wanted to talk about some of the interesting things with the updates. And I just have a couple of clinical scenarios to go over, and we'll go over some of the US MEC criteria again. So we have a patient here who's 28 years old, G1P0 is pregnant, and she's being counseled during her OB visits for her postpartum family planning. She's not planning on breastfeeding, and so, what are the things we talk about? What options can we offer a woman when she becomes postpartum? Can we offer her the IUD, either type? Can we talk to her about progestin-only methods? Should we talk to her about combined hormonal contraceptive methods? Which one should we use? Why is postpartum contraception important, right? It's to avoid unintended pregnancy and short interval births. It's really a good time to talk to, when women are pregnant or they're immediately postpartum, it's a really good time to talk to them about contraception because they're motivated if they don't want to go through what they just went through again now. And oftentimes they're accessing healthcare at this time as well, so when they're pregnant or postpartum too. And so that might be a good way for us to be able to talk to them about contraception and actually have them use the method. And as we mentioned yesterday, in our adolescent pregnancies, about 20% of adolescent pregnancies, 20% of adolescent births are repeat births again. And so we really want to prevent patients from getting pregnant when they don't want to be. So if you look at the US MEC little chart for hormonal methods for postpartum women who are non-breastfeeding, this is what their chart looks like. So they divided within 21 days, 21 to 42 days, and then greater than 42 days. And then you can see for combined hormonal contraceptive methods, right? Combined hormonal, who are within 21 days of giving birth, it is a 4, right? It's an absolute contraindication. For somebody who's within 21, so between basically 3 to 6 weeks postpartum, and if they have other thromboembolic risks, right, it's a 3. Probably should use a 1, right? Because you can see the progestin-only methods are a 1. If they're within 3 to 6 weeks postpartum without other risk factors for thromboembolism, combined hormonal contraceptives is a 2, so it's acceptable to use, although I think traditionally we all don't, right? We usually wait for, if we're going to talk to patients about combined hormonal contraceptions, I think traditionally we all wait here for 6 weeks postpartum. But just for you to know that there is a distinction here. If you are going to think about inserting an IUD in a postpartum patient, so the way the chart is divided up is for the progestin IUD and the copper IUDs. So there is the choice of placing it in within 10 minutes of delivering the placenta. There is the choice of inserting it from 10 minutes of the placenta to up to 4 weeks postpartum. And then there's up to 4 weeks postpartum, and then there's the woman who has postpartum sepsis, right? Important to know that in a woman with postpartum sepsis, an IUD is not recommended, right? It's an absolute contraindication. And then in all the other scenarios, it's about 1 to 2, right? So it's safe. There are some studies that show that if you put it in within 4 weeks, that there's a higher expulsion rate. Again, it's up to you to decide. It's what your hospital actually has available to use, but it is something that can be used. And again, in our practice, we don't do this immediately postpartum. We don't offer that to patients. We offer them when they come to their 6-week visit, as long as they have no other contraindications. How about we have a patient who's 38 years old, para 2, with diabetes. She's been using for condoms, but she's looking for something more effective. So what methods can we use for her? Again, we go to our cute little chart, and we look at what our chart helps us decide what we should do. So again, so the type of method that we use for a patient with diabetes depends on the severity of her diabetes, right? And then you can see how we have, and it's basically the level of vascular severity they have of of their diabetes. So again, for combined hormonal contraceptive methods in women who have severe diabetes, right? They either have nephropathy, retinopathy. Those patients fall into the 3s and 4s, right? You really should be looking for better methods, not better, methods that will have less adverse effects for that patient. And so you can see what other choices that you have, okay? But if you look up here for diabetics with non-vascular disease, right, up here, whether they're insulin or non-insulin dependent, right, all the methods are 1 to 2, unless they have some other contraindication, right? Always remember that. Like, this is for each particular condition, but people may have more than one medical condition at a time, right? We know that. So you have to look at it in that context. So that's that. So how about our next patient? So we have a 30-year-old female with a history of migraine headaches, and she reports that she has some light sensitivity when she gets her migraines. She doesn't have, per se, visual auras where she loses vision. She's interested in starting contraception. What can we talk to her about? Again, same sort of choices. What do we talk about? So we'll look at our little chart again. So for patients with non-migraine headaches, all methods are 1s. And then there's the little star, and if you see little stars, you just want to read what's underneath it. So with patients who have migraines without auras, which menstrual migraines are included in those, without auras, then combined hormonal contraceptions, right, is a 2, right? It's acceptable to use, and all the other methods are a 1, which there's no risk to them. If they have auras, look, auras, migraines with auras, combined hormonal contraceptive, it's a 4. But our other methods are a 1, right? So this will help you figure out what you should be using and what you shouldn't be using in that patient with the migraine. How about we have a patient who's 19 years old and she comes in and she wants an IUD. She's had a history of chlamydia before it was treated, and she's had a new partner since then. Given her history of a sexually transmitted infection, can we place an IUD in this patient? Let's see, I don't know, let's see what US MEC says, right? So if you look at it, right, so if a patient has had a history of an STD, if they've had trick, if they've had other STDs like chlamydia would be counted previously, right, it's a 2. If for IUDs, right, this is the IUD categories, both IUDs, it's a 2. But who is it a 4? It's a 4 when somebody has purulent cervicitis, right? They have active PID. We're not going to go insert a foreign object into her uterus and worsen the clinical problem that she already has. And so that's the person to really look out for. We also, again, generally it's how your practice is set up. It's sort of your population who's at risk, but we generally do gonorrhea and chlamydia testing prior to IUD insertions. We usually like to have an updated one within 90 days, or we would even repeat it if the patient by history reports any significant changes in her sexual history. But we do document, we do the testing and document, and your examination will help you figure it out as well. And this is, again, for IUD initiation here, it's a 4. The IUD continuation is actually 2 here, which is interesting, right? Because if somebody has active PID, they're telling you it's a 2 in terms of continuing it. So they're giving you that sort of a little bit of a flexibility of deciding whether or not, when you're trying to treat this patient with active PID, should you remove your IUD. And I would say that if you do your current treatment and the PID is not getting better, right, removing the IUD makes sense. Because that could be the nidus for the infection that she has. Okay, how about this one? How about this patient who is on oral contraceptive methods, and now she needs to take an SSRI for depression? What do we do about her? Are they going to interfere with each other? So there's a little thing for psychotropic drugs, and you can see, right, for SSRIs, it's a 1 for all the methods. For St. John's wards too, they've included that one in there too, and it's 1s and 2s. And again, so if there's no other contraindications, patients are allowed to continue or start on their SSRI while they're on a hormonal contraceptive method, if there's no other contraindications. So how do we access this? So you can go to CDC's website, you can search US MEC and it comes up, and then you'll find a little chart, and it's like a document that's about this big. It's really nice if you print it out and just put it on, we put it in the office so that it's easily accessible. There's also an app, it's a free app that you can download for the US MEC and the SPR. And it's really easy to use it because you can search by medical condition. You can either search it, type it, or the list comes up of all the medical conditions that they address in their guidelines. Or you can go by method. You can choose your method that you want to use and then find out whether or not you can use it in a patient with a particular medical condition. So it's actually really, really user-friendly. And then, like I said, you can access it online as well, and you can have the printed out document with the color chart on it. It just really is very helpful. Any questions? Speechless. Good. I would just advise everybody to take a look at it if you haven't already. And when updates come up, it'll be posted on their CDC's website as well. And I just find it really helpful.
Questions? No.
Okay, well, that was very helpful. I plan on using that.
I have
Thank you.
one question back here.
Go.
So in the Mirena packet, there's a recommendation that if somebody's had PID, you can't get an IUD placed unless you've subsequently had a term pregnancy. What are your thoughts about that?
I was not aware of what that says in the package insert. No, I was not familiar with that.
Yeah,
and I don't think that's addressed here.
It's not addressed in the MEC.
I don't know what. I don't even understand. I don't understand why that would be the case.
I don't understand it either. So I don't personally I just tell them about that recommendation, but I still put it in.
Yeah, I think if there is no active current infection, right? I think if you follow if you go by the guidelines that are evidence-based, I think it should be okay.
Okay, but do you know the reasoning behind Bayer's recommendation for that?
No. Okay. Unless anybody else does, I don't.
I don't know if this is their actual reasoning. I do know, and this is for everybody who puts those IUDs in, that package insert that they have to sign is really important to get them to sign, because the manufacturer's reasoning for that insert is that they have received the booklet and know all the complications. So if the patient doesn't sign that booklet, even if you have a signed consent, the company has absolved themselves of any responsibility. My guess is they're putting things like that into their booklet. It sounds to me very medical legal. If somebody now comes back and they have tubal disease, which is a high incidence after PID, that they can't blame the Mirena for it. That would be my guess. I see lots of heads nodding yes. I think it's a medical legal thing.